I like to have a little bit of humor. We will record this session. If anybody has any objections to that, please speak now or forever hold your peace. You can put any questions you have in the chat while we are going through the presentation. So let's just hop in, and I'm going to share my screen really quick. And I should have this set up. So, fundamentals of theory and practice of clinical supervision. As I said, Dr. Anthony Rivas, an LMFT and a licensed addiction counselor in the state of Colorado. I'm also a master addiction counselor and a U.S. Department of Transportation substance abuse professional. A little bit about my background. As I said, when we first started, I have conducted clinical supervision in Colorado for licensure and for interns. I am an expert witness in El Paso County, in Colorado, and 18th Judicial District for mental health and substance use concerns. And I have taught at the University of Colorado, Colorado Springs, had a private practice, taught at Metropolitan State University of Denver, and currently teach here at Sacramento State University in the Masters of Science in Counselor Ed. So clinical supervision is predicated on having brave conversations. What do we mean by brave conversations? We mean that we have to be able to have a relationship with our supervisee that is conducive to honest and frank conversations based upon trust and knowledge. And we're going to get more into what it looks like to be a supervisor. Now, supervision can be broken into two types of supervision. One is clinical supervision, and that is anything happening within session. And we're going to talk more about both of these. That is, techniques. Those are anything that happens between the client and the intern or the clinician in training. Then we have administrative supervision, and that is policies, procedures, usually at the agency you work at, and those two both carry over when it comes down to notes, clinical case notes and paperwork. So there's some cross-pollination with both of them. Important thing to know about both types of supervision is they both carry direct and vicarious liability. i.e., you can be grieved and sued for failure to provide adequate supervision in either one of those realms, which would in turn cause your intern or your supervisee to inadvertently possibly commit insurance fraud on the administrative side, or to do something unethical or illegal on the clinical side. And so we're going to talk a little bit more about vicarious and direct liability as our discussion goes on. So we're going to start off once again, brave conversations happen here. Nothing in the supervision relationship can be taboo, much like in our clinical relationships. We have to be able to have that open and honest communication. So the outcomes, my hopes, my student learning outcomes for y'all to understand the characteristics of effective systemic clinical supervision, understand the needs of assessing current counselor level for their knowledge, skills, and dispositions as they are in your care for the students here, to understand how you're being assessed, and then to understand methods for giving supervisees appropriate feedback, right? Feedback does need to be immediate and objective, not based in emotion. Regardless of what personal feelings, if you like your supervisee as a human being and they're a kind, gentle soul, that's fantastic, but it cannot color the lens of their clinical skills. And that's sometimes hard for new supervisors and for supervisors who've been doing it a while to divorce that emotion from the objective needs of the field. So what is clinical supervision? Clinical supervision is a clinical intervention. Bernard and Goodyear define it as listed here, that it is provided by a senior member of a profession to a junior member of the same profession. The best outcomes happen when individuals are trained and taught by individuals who hold the same clinical identity, licensure identity. And that's what they're talking about here, members of the same profession. The relationship is evaluative. It is evaluative, and we need to hold on to that because we are evaluating their knowledge, skills, and disposition in every move they make. As a clinical supervisor, you are responsible for everything, and I'm going to be heavy-handed on it during this presentation, everything that your supervisee or your intern does in that session with a client. Clinical supervision extends over time and has the simultaneous purposes of enhancing the professional development and functioning of a junior member, monitoring the quality of professional services offered to the clients, and serving as a gatekeeper of those who are to enter the particular profession. How many folks here feel comfortable with that term or the role of gatekeeper? And I can see on the screen, just put a little check mark or a thumbs up. Okay. Gatekeeping is one of the foundational and fundamental roles. Think about it. Nobody comes to therapy on a good day. Any person that is sitting across from you is in a vulnerable population. They are counting on the therapist, the intern, the trainee to have their best interest and to treat them without bias, with the best possible best practices and evidence-based treatments that they can. And that's what gatekeeping ensures, that those who are ethical and legal practitioners continue into the field, and those that cannot be are not in the field, and those in between are remediated to enter the field or not enter the field. And that is the role of gatekeeping. It's not to knock people out and prevent them from being in the field for no reason. It is justifiable. And I want you to think about that when you're working with your trainees and your interns. Think to yourself at every interaction, would I trust this person treating a member of my family? Would I trust this person as a colleague and a peer? And if not, what can I do to help them remediate those skills and to grow as a professional, or to help them find an alternative to becoming a clinician? Clinical supervision is a process of clinical practice provided by a counselor and modified or approved by the supervisor. You are the captain of the ship when it comes to therapy. Your supervisees turn the boat when you tell them to turn the boat. And eventually, and as we talk a little bit later about theories of supervision, eventually get to the point where they can turn the boat themselves because they are starting to move into a professional and they can be trusted with it. But first year interns coming, for their first practicum or their first, internship, or even individuals just out of grad school, they need a lot of support. And they need a lot of support from their supervisors in order to guide their practice. Supervision has to be hierarchical. Just like clinical work is hierarchical, there is a power differential because you are evaluating them. You are guiding them. We are not equals until they become a member of the field, because that creates a disservice to our supervisees and our interns. And as I said before, the administrative component with vicarious and direct liability. How many people on the Zoom were aware that you could be sued by your intern's clients if they fail to provide adequate care? Direct liability. So we are in a field that holds quite a bit of power, in the sense that we are trusted with people's secrets, their health, and their well-being. Relevant factors influencing supervision. One of the things when we were talking about earlier, as a clinical supervisor, is not only to safeguard the profession, it is also to help our trainees, our supervisees. I'm just going to use the term supervisee for the rest of this, just to make it less cumbersome. By mentoring them and working with their professional development and training them properly, we ultimately protect the field, because they're going to go out and eventually, after X number of years of being licensed, they're going to be able to then supervise, and they're going to supervise the way they were supervised. And so the more we put into that supervisory relationship and expect our supervisees to bring to that relationship, the stronger we make our field and the more protection we offer our clients in session. So things we need to train our supervisees on: contextual and cultural issues, making sure that we understand multicultural competencies and how that affects our client, from socioeconomic status to race, gender, ethnicity, to understand how the world's impacting them. State and regulatory issues. How many supervisors on the Zoom are familiar with AB 462 that just passed January 1, 2022? Nobody. Okay. AB 462 was signed into law by Governor Gavin Newsom in California, and it removed the onerous obligation for students to intern or trainees, once they graduated, from acquiring hours in a hospital setting. They no longer need to do that for the LPCC licensure, nor do they have to have a letter from the BBS indicating they can work with families, couples, and children, because that training is provided in their graduate program. So they no longer need to provide that letter. Supervisors no longer need to provide that letter. It also, how many LPCCs do I have on the Zoom? Checkboxes or licensed professional clinical counselors? You got one. You got one. Okay, two. Just one. Okay, my LPCC folks, that law also indicated that LPCCs can work with children, couples, and families in the state of California without a BBS letter. It also allows for LPCCs, did get clarification for this from the board, to supervise not only APCCs, but also associate MFTs for their hours once. So those are some things, keeping up with the board and being on the mailing list is one of the things we do teach our supervisees, because laws change. Ethical issues, legal issues, and we're going to go through some vignettes shortly. Performance and evaluation issues. Most of us get into the field to help. And we often forget about those administrative roles of looking at and assessing skills. And we base it off of sometimes arbitrary measures, but we need to become more data-driven. Understanding documentation issues, different types of notes that students are trained on. They need to, understand what your particular agency or what type of case notes you use. Also, what needs to go into a case note. If a case note has too little content, it's worthless. If a case note has too much, it's cumbersome to read through. And it needs to be somewhere in the middle, right? How you're going to observe your supervisee, and then the administrative, the clinical issues that come up, the relationship, the personality differences. So all of these check boxes are not only conversations for you to have internally and intrapersonally, but also have interpersonally with your supervisee or trainee prior to accepting them as a supervisee under your license. Having these conversations in order to set up basically a learning plan with them. So, any questions at this juncture? I know I said there was going to be a lot of okay. So starting off there with the relevant factors, the next area of supervision for you as a clinical supervisor to pay attention to are your theory of clinical supervision. How many people on the call have a theory of supervision, knew there was a theory of supervision floating around out there. You can use the green checkbox or the thumbs. Okay. And now of those checkboxes and thumbs, how many of you all have a theory of supervision that you can explain to a supervisee and demonstrate through your supervision that you adhere to? That's the next step, right? And I'm glad to see some checkboxes on that second half. Understanding how counselors and supervisees develop, not only understanding your models, but how to explain it and how to use it. How to assess for readiness. Once again, going back to the cultural and contextual factors. Just because somebody has come into the field, it doesn't mean they have a full understanding of the field. There is cultural capital that comes along with each training program. And it is important for the supervisee also to understand, or the supervisor it's important for the supervisor to understand the supervisee's background and be multiculturally competent and sensitive when working with supervisees, understanding what is culturally normative for them and working with them in a way that doesn't harm the supervisee as well. Your ethical and legal obligations to your supervisee, dual relationships, ensuring that you are a model for legal and ethical practitioner, that your supervisee can look to you for questions, but then you're also operating in a way that doesn't put you or your supervisee at risk. And then the last one that most people don't really enjoy is monitoring their performance, evaluating their clinical skills, behavioral contracting, and gatekeeping functions of the supervisor. Once again, our role isn't to be biased and exclude people from the field. Our role is to be objective observers of clinical skills and practice, knowledge, dispositions, and skills, and to be able to view, assess, and monitor, and if need be, gatekeep, welcome people to the field or help them find an alternative in their future. So, how many of you all were just tossed into being a supervisor the first time you supervised? Got your license, your agency said, fantastic. Starting Monday, you have interns and you have license eligible individuals. Unfortunately, that's the way our field works. And I'm starting to see the check marks popping up. And unfortunately, that does a disservice to our supervisors that are coming into the field, because it really is just being, kind of thrown in the deep end of the pool without all of this information. Some things to pay attention to as you're supervising and you're growing. You may have been forced into that role, and now you've come to really grow and flourish, and you're going to trainings, and you're really taking on the identity of a supervisor. You can still ask yourself, what are my personal attributes that I would like to carry on going into the future? Who are you as a person? What do you bring to your role as a supervisor and as a clinician? Are you authentic and congruent in your role of supervisor and clinician? Or do you, we can be going through doubts of our skill set, imposter syndrome, all of those things come up, but really paying attention to what do you bring to your role? What do you bring to your supervisees? Going back again, what is your philosophy of systemic clinical supervision? What does it look like? What is your, understanding of what the relationship of supervision? What are some fundamental issues that you can identify in supervision? And I'd like everybody to take the opportunity right now, and I'll keep going around this, but I would like you to throw some things in chat, that just one or two that you think are some fundamental issues that happen in clinical supervision, and we'll make it a little more interactive versus just me talking at you. Other parts is, theoretical issues. If you are, your theory of supervision is a developmental model, but your personal therapeutic theory is CBT, let's say. How do you train or work with a supervisee whose theoretical orientation is narrative, right? Those theoretical issues do come up. How do you work with somebody, with a trainee who is solution focused and you are a narrative therapist? Can that cause concerns, or is that something you think you can work through? Regulatory issues, are you allowed to, first and foremost, is your license allowed to supervise? And what is required for licensure and certifications in your particular area for your particular license, and for the licensees or the license eligible supervisees you have, or the interns? Because one of your jobs is also educating them on what they need to get licensed. It doesn't mean that duty falls just purely onto the school or the training program. It is also your role as a supervisor to help the student intern understand that, and then the recent grad who's either an APC or associate MFT understand what the licensing requirements are and help them with that. And another attribute is, think about it, what is the best and worst of supervision? What is the best supervision that you had? And what was the worst part of supervision? And this could be something that's not even related to clinical, right? I was a data analyst for a large data warehouse company in the United States. And I would crunch numbers all day long, just running stats and sitting there in front of a screen with my earbuds in. You ever get that weird feeling that somebody's staring at you from behind? I would get that pretty much about an hour into work. And we had an open floor plan in the office. And I would turn around and I would see my manager behind the cubicle like this, just eyes, staring at all of us data analysts, just watching us, kind of like an alligator out of water, to the point where we had to take the person aside and tell them, if you don't trust us, you probably want to get a new team of data analysts. The funny part was that this individual didn't understand data analysis to begin with, but they would sit there and just watch us. That doesn't breed an air of trust, right? And we talked about that just at the beginning, that with supervision, we need to trust our supervisees to a level, and they need to trust us very much so. And the best part of supervision is being able to establish that relationship where your supervisee, if something does come up, that they understand, no matter how bad it is, they need to come to you and have that conversation. The best part of supervision is knowing that everybody who walks out of under your supervision is the most ethical and legal practitioner that you could produce. And the relationship of them going out there when they become a supervisor, that they are carrying on that trend as well. Any thoughts or considerations? All right. Some additional considerations for supervisors and holes and gaps that usually come up are the supervisor competencies. As I asked earlier, and everybody, I think you being brave enough to raise your hands, most of us were tossed into supervision. Coming from a different state here with my clinical license in addiction counseling, licensed addiction counselor, we had to take 21 hours of supervision training for our license. It's a clinical license. And I was really thankful for that, because that 21 hours actually covered all of these competencies, contracting with clients, understanding what the state of Colorado required for licensure, understanding what was required from our ethics board, ACA and NADAC. And it really made me feel more secure as a supervisor having this information. Whereas many of my peers on the LPC side, we're much like almost every other state and MFTs, we're just kind of tossed into their agencies being a supervisor. And I felt that I was a little bit more of at an advantage with that. And I was quite thankful for that. Not every state requires that, but it is beneficial the more you can do it. I know AMFT, the American Association of Marriage and Family Therapy, provides or has a certificate for approved supervisor, as does NBCC, has the ACS for LPCCs. That's approved clinical supervisor credential as well. And those additional trainings I would highly recommend. This one is not designed to be an end-all be-all. And for my LPCCs and the students that I see in the room, as you get your LPCCs, I would encourage you to do that ACS through NBCC. And then for my supervisors and my MCFC students in the call, I would encourage you to do your AMFT approved clinical supervisor credential as well, because it really does enhance your readiness to be a supervisor. With that, supervisor competencies. These are things that you professionally, legally, and ethically should be more skilled at, or at least more skilled at the least, but hopefully an expert in prior to supervising a student. And that is screening, assessment, and diagnostic evaluation of clients, understanding diagnostics and how to assess for mental health concerns, substance use concerns, being able to screen for appropriateness for different treatment levels. If you are working with substance use, understanding ASAM and how to place clients appropriately. Should be an expert in counseling and counseling theory and how to work with clients and appropriately treat clients. Case management, because working with a multidisciplinary team or as a requirement for resource management and parceling out services, have an understanding of case management. Treatment planning as well. I found through my travels in clinical work that treatment planning was often a blank spot. And for the folks that deal with Medi-Cal, Medicaid, Medicare, you'll understand the term the golden thread. Right? Golden thread is what's on the treatment plan must directly align what's on your SOAP notes or your clinical case notes. And then that directly lines up to what you're billing. So when you're audited, the auditors come in and look at what you're billing and work their way backwards and making sure that everything lines up. Everything is, treatment planning is client driven based upon their needs and what clinical concerns they have. But everything must follow from the treatment plan. So understanding what an accurate and complete treatment plan looks like. Understand the difference between consultation and supervision. Supervision is hierarchical, so the individual or a professional in your field that has more experience than you do. Consultation is peer-to-peer. As even licensed clinicians, we should always continue to do consultation with our peers, and we should even still be seeking supervision, because that not only models for our supervisees that we ourselves understand that we don't know everything, it also helps us be legal and ethical practitioners, because if we have a question or concern, we know that we can reach out to somebody that has more time and more experience in the field. And that is something to help both you and I as practitioners. We need to be competent minimally, expert preferably in crisis intervention, understanding client and family community education, psycho-ed, referrals, when to refer, how to refer, why to refer, and report writing and record keeping. So I don't want anybody to answer this question, but think about it. How often do you get to do your notes immediately, right after working with a client. I can guarantee you, if you work in an agency, that is never, you don't get to do it, right? It's the end of the day when you're supposed to go home. That's when you're knocking out your notes. And unfortunately, that just happens. If, private practice, we can usually schedule out our day. But, ensuring that our supervisees and we ourselves are doing accurate reports and making sure that our record keeping is untouchable, so to speak. That being said, something I always tell my students when they're writing the notes, if it didn't happen, right, it doesn't go in the case notes. And if you didn't write it in the case notes, you need to make sure that you either amend them, right, and get that information in if you accidentally left something out. Because if that case note goes to the file and it's not in there, that's problematic. If there is something of clinical concern or something that happened in session, and that can oftentimes be guilt by omission. And so paperwork is very important, albeit as helpers, we oftentimes look at it as the problematic side of our field. It is an important side of our field because, as I said earlier, with treatment planning, it drives treatment, it helps with billing, and it ensures that if something happens to us, our clients can be taken care of by a clinician that takes over for us. You see some things in the chat. So I saw in the beginning, I felt I was challenging to navigate different functions, teacher, coach, mentor, consultant, and also be a model for what you want the supervisees. Yeah, and you said, as time has gone on, has become easier. Support and development is my concern as counselor and training. Development, okay. So working with people as supervisors, it does become easier over time, right? Because we start to settle into that role. As supervisees, I kind of want to shift gears and talk about them. These are the competencies that your supervisor should have. And this is an expectation when you do go for an internship or you do seek out a supervisor for your licensure hours. These are areas to inquire of their competency on. How strong are they within these different realms? So supervisors, these are the roles that you should be strong on. And then you're looking and assessing where the strengths and weaknesses are with your supervisee. And the supervisees, conversely, are doing the exact same thing. Where do I need more growth? I need to be honest with my supervisor. And I also need to acquire where they're strong, where they're extremely strong at, or if there's any gaps that maybe I need to seek supervision somewhere else. So, questions for supervisors to ask themselves. Goes back to a little bit ago. What is my theory, philosophy of supervision? How does it fit in with me as a supervisor? Do I understand it? Can I use it effectively when working with my supervisees? What is my structure of supervision? Am I willy-nilly as things go, or am I pretty structured? Do I tell my supervisees what my structure of supervision is? What are the cultural, idiosyncratic life experience and family of origin issues that experience my supervision? What's going on in me that may be unresolved that's popping up when I'm working with the supervisee? We often forget that we bring ourselves and our family of origin concerns into the room. Also, what are the students or the supervisees' cultural, idiosyncratic life experience, family of origin issues that influence their ability to receive supervision? How do you as a supervisor manage power, values, core beliefs in the supervisory system? Do you think you're going to butt heads with supervisees? Do you think you're going to have differences of opinion with supervisees? Yes, right? Just like with clients. There's countertransference and transference that occurs. How do you ameliorate that? And then how do you manage legal, ethical, professional, and contextual issues in the supervisory system? Who do you rely on for that information? How often are you going to BBS to check updates and regulatory issues? How often are you going to symposiums? Trick question, because you're here today, but going to ACA, going to AMFT, going to, I forgot the school counseling one, just escaped me, right? ASCA, going to their websites, going to their conferences. Who do you lean on to update you on anything happening within the state? Who do you lean on for consultation? Do you have a mentor, a supervisor that you lean on? And these are things to also explain to your supervisees, because that goes into that modeling. But it's important questions for you to ask yourself. And for you today, as I'm asking you these questions, if you don't have an answer, that's okay. It's not a wag of the finger. It's not an admonishment, but that's a gap. That's a gap in your supervision that I would like you to fill. And when we leave here today, I would like you to go back and really look at those questions and say, okay, this is an area I need to bolster up so that I can provide legal and ethical supervision to a new generation of supervisees. Other questions continued, right? How do you manage transference and countertransference in the supervisor-supervisee relationship? How do you address areas of clinical skill development and professional experience? Can you give your supervisees 100% of every clinical experience out there? No, you can't. It's based on what kind of client population you're working with and the different populations you serve, right? But how do you address clinical skill development with your supervisee based upon your population? And how do you make sure that you are monitoring those skills, right? And I'm going to put a bold statement out there. If a supervisee is just all right, is that good enough? No, I told you I'm making a bold statement. Supervisees, all right, our job is to see if we can make them better and help them, right? We want to make sure that every client that walks through that door that the supervisee works with is getting the best possible care. 0 questions asked. They understand they're working with a trainee, but they're also counting on us as supervisors to keep strengthening that trainee so that their care gets better and better and better as that trainee grows. And so I encourage you, supervisees, just all right, think about ways how you can help them be better. Know the resources, know what resources are out there, what trainings are out there to encourage them, the professional development wise, that you yourself can partake in and that you can also help them partake in. How do you limit your liability, vulnerability, accountability, and responsibility in case of supervisee misconduct? First off, have good malpractice insurance if you're supervising, first and foremost. B, seek consultation and supervision for yourself. C, make sure you are documenting each supervision session with case notes. How many folks do that? Every time you meet with your supervisee, you write a case note about that supervisee meeting. Document, document, document. If you don't document, it never happened. If you have to defend yourself in court, you bet, and you didn't document it, now it's your word against theirs, right? That's the scary end, but the good end is it also gives you a starting and an ending place when you're working with your supervisees. As you go through your supervision records, you can see growth. You can identify where they have grown. How many folks evaluate their supervisees outside of what's required by learning institutions? It's a kind of a rhetorical question, but technically we're evaluating our supervisees every time we meet with them. This should be an evaluative process. What did you do? Why did you do? And what made you conclude that you should do that? That's an evaluation. That's an evaluative piece of understanding why they did what in session. That helps limit your liability. Having open, honest communication helps and knowledge base helps prevent supervisee misconduct unless it is truly nefarious. It does limit your liability because they're coming to you and seeking supervision. They're coming to you for skills development. And so that really does limit your liability in that role. And then what do you do with supervisee misconduct? At what point do you know where they need to be sent to the board and grieved to the board, or an ethical violation sent off to ACA, ASCA, AMFT, the professional board that they belong to? How many folks feel comfortable with that? Okay, so I'm going to ask a question. And think to yourself, because this one usually, how many people, almost everybody's probably been to a physician at some point, feel comfortable going to a physician that is all right, messes up, all their medical supervisors were just like, yeah, they'll be fine, but they continue to mess up. How many folks would feel really comfortable going to that physician? Okay. How many folks would feel comfortable going to a physician that is being held to a high standard by peers, by supervisors, and knows that their supervisor would take the steps necessary if they are providing poor care and misconduct? So then why are we allowing therapists into the field and we feel ourselves that we don't have the right or the obligation to the greater community to protect the community from malfeasance and bad acting? Y'all thought this was going to be a fun one, didn't you? But that's how we respond to supervising misconduct. Supervisees will mess up. We all mess up, right? It doesn't mean it has to go directly to the board or to code, our ethical boards. If it's a growth opportunity, but sometimes supervisees, they will do something that unfortunately takes it to that next level. And if we ignore it, we are just complicit as them. And supervisees need to have that conversation with you as a supervisor, much like our clients have with us. When we need to break confidentiality, that needs to be a conversation, a brave conversation we have with our supervisees, is I'm here to train you, but I'm also here to stop you if this occurs. And we're going to talk about ethical decision-making. ACA actually has a really nice little ethical decision-making tree out there. The importance of a theoretical model gives us guidance, gives us a roadmap of where we are and where we need to go. But it also, we need to understand it. And so it's not just words, we just throw them out there, right? We need to actually understand what it means to supervise from that framework, just like having clinical theoretical orientation means we actually really have to understand from the base to the top of what we're doing each and every session with our clients from that theoretical framework. And if we choose an eclectic framework, we need to be able to identify each and every moment in that session why we're doing this particular skill or using this particular tool and document it. And this comes back to our theoretical model as well. So some supervision models, and I'm going to tie it all together before we break out. Supervision models, according to Bernard and Goodyear, and this is something, if you're interested in it, there is a book, Fundamentals of Clinical Supervision by Bernard and Goodyear. The hard copy is 106 from Pearson. You can get the electronic version, I think 39. I just checked it. I don't get money from them, but it is the textbook used in the doctorate program for counselor ed and supervision. And we use it. AMFT uses it as well for theories for the approved clinical supervisor. MBCC uses it. Even SAMHSA, the feds use it for tip 52 for substance use counselor supervision. That is tip 52 from SAMHSA is a free guide, and it is aimed at supervising clinicians with a specialty in working with individuals with substance use disorders, but it actually covers quite a bit of this. And so we're just going to kind of look over different supervision models. I'm going to go a little more detail into the one I mostly that I use. And so we have models grounded in psychotherapy. We have developmental models and supervision models. Now, models grounded in psychotherapy, we're going to go back to that supervisory relationship. Within the supervisory relationship, it walks up to the line of psychotherapy, but it never crosses over. And we as supervisors must understand that line and know when to refer our supervisees out to their own counseling. And I recommend as best practice that your supervisees be in their own counseling during any sort of internship or when they're accruing their license, because this is a time of great stress. And something I told my supervisees this semester, and I truly feel it in my heart, is there's no way to ever train somebody on the amount of pain that they're going to hear from their clients until they are face to face with it. And so I would encourage them to be in their own therapy during this time, because that's the only time you can process it out. And we're in a weird field, right? You have a rough day, you go home, and unless you're married to another counselor or somebody who has to keep secrets, right? They don't understand what your day looks like and feel like it was a bad day. Most people have regular jobs and you can talk about it. What happened? And what do we do as therapists, clinicians? Yeah, that's pretty much it, right? You just take that deep breath and it doesn't have an outlet. And so I encourage our supervisees, but supervision walks up to that line, but doesn't cross over. And during that time, we do discuss transference, countertransference. We do look at the intrinsic and internal motivations that our supervisees have working with their clients. What's going on internally with them? And pretty much almost every theoretical model has a model of supervision. Psychodynamics can come from an analytical point of view. Humanistic is a client-centered existential approach. Cognitive behavioral, pure behavioral, systemic, etc. Developmental models, there's quite a few. I particularly like an IDM model. I'm going to talk a little bit about it. And then the supervision process models are quite a few. And I encourage you to look at which ones that you like. And then we also have second generation models, which are combined models using two models. So humanistic and maybe IDM, target models, those are just focused. So we can look at a supervision model that's maybe coming from a multicultural lens, or purely from a multicultural lens, or maybe purely from a feminist lens. And they're very targeted. And then common factors model is kind of like an eclectic approach. The hard part with the common factors model is you have to really know all the models really, really well in order to do it effectively. But the point is, whatever model you choose, make it your own. Understand it. Understand how to use it, and understand how to explain it to your students, because they'll be able to receive it. If they don't understand what's going on, it's going to be really hard for them to take it in. I like the integrated development model, IDM. Basically, it looks at multiple levels of counselor development. Starts off with a neophyte, limited training experience, transitioning up, and then all the way to an integrated approach. There's levels and characteristics, and I like data, so it probably, this explains why I like this one, because we have 4 levels, 1, 2, 3, and 3I, limited, transitioning, personal approach, use of self and therapy, integrated. And then we have 8 domains that those 4 levels are assessed at. And this is a really small screen. I apologize. I try to squeeze it onto one slide. And so those 8 domains that we're looking at are the intervention skills of the student, our supervisee, their assessment techniques, their interpersonal assessment, client conceptualization, case conceptualization, individual differences, theoretical orientation, their understanding of their theoretical orientation, treatment plans and goals, and then professional ethics. And so across 8 of these domains, a supervisee may be at 3I across 3 of them may be at 2 across 2 of them, and then across 3 at the other ones. I know where we need to grow, and I can explain to my supervisee, this is the area of growth we need, because I see you're just developing, bringing yourself into session. Over here, I can see you're integrated. We need to keep working on that and make sure that that muscle memory is really strong. And this is the area where we need to grow. And so I can explain to students and licensees or future licensees that this is how they're being assessed across these areas. And they can see it on paper. I even actually have a nice little Excel spreadsheet with macros, so I can go in there and type their name and put where their skills are at, and we have something concrete. At each session, we can look at that and understand their growth over time. And so that's what I mean by understanding what your theoretical orientation is, not only clinical, but supervision. And the last part of it is explaining to my supervisees that my interventions are set up in a certain route. So when a supervisor comes in, I basically explain to them at the beginning, you're a neophyte, you have limited training experience, right? So they've gone through 2-3 years of grad school. And there are, by the time they get to field work, they've had limited real world experience, right? It's mostly theoretical. So we're starting pretty much from ground level, and we're going to be working with real people. And the idea is we're going to have this really big growth curve by the end of the year. And this is how I'm going to assess you. And then this is how I'm going to intervene. A cathartic intervention, right? A catalytic, a supportive, interventions that elicit effective reactions. Catalytic, the Socratic questioning. Sometimes my students hate how Socratic I get, but it works for me, and I explain why I do what I do. And interventions that validate their experience in that supportive realm. We've all been there as a supervisee, and our job is supportive, high expectations with high support, right? We can't have high expectations with no support. We can't have high support with no expectations. Both have really poor outcomes in the literature for working with clients. Other interventions are authoritative, right? When we look at family systems and parenting styles, authoritative parents have better outcomes for their children. Authoritarian and permissive and neglectful do not. And so we want to have authoritative interventions, prescriptive, informative, and confronting. So this is what the expectation is to do. Here's the advice. Here's how you do it. This is probably a way you want to go, helping them with their case conceptualizations, providing information, psycho-ed, etc., and then confronting. If you noticed earlier, I'm very big on why'd you do it? What made you go there? What do you expect the outcome to be from it, right? Understanding their feelings, attitudes, behaviors associated with their clinical case conceptions. Any questions so far? We're almost at the end, and we can break up in a minute and do some case vignettes. So based upon their information and what we've talked about so far, is our role is to understand our supervisees and to be knowledgeable in our field. I'll distill down what I just talked about for an hour to those bullet points. To be ethical and legal practitioners, we need to understand the requirements of licensure, the requirements of our ethical bodies, our licensing boards, and any university partners that we have in order to have the best outcomes for our students and our supervisees. And we need to be able to evaluate at all levels. We need to be able to and comfortable with and ready to assess clinical competence and impairment. How do I know when my student or my supervisee is impacted beyond the scope of just being stressed or overwhelmed? When do I know I need to stop practice? Am I comfortable stopping practice? I'm going to give you some advice that I give students and I give clients and I give supervisees. As a supervisor, Get comfortable being uncomfortable, because we make a lot of uncomfortable choices in our life, right? And it's always to protect the client. And that's where we need to understand what supervisee's impairment is. Sometimes they're just stressed, and that's fine. We can grow, we can help them, we can walk them through it. And other times we cease practice. And I've done that several times in my career to success, where the student was able to get the help they needed, or the supervisee was able to get the help they needed, and then they were able to return back to working with clients. And that's the best outcome, because that shows them, when they're professionals in the field, to screen themselves. One of the greatest gifts I was given by a professor in grad school was from my family systems professor. She worked with high conflict divorce couples in Boulder, Colorado, and that was her bread and butter. She herself went through a high conflict divorce, and she came back to class and she was telling us, we were walking through a lesson, and she explained that she was just off that day, and she was grieving that she closed her practice down to current and new clients. And she used that as a moment to highlight that as clinicians, that is our obligation. If you are impacted, she knew herself she could not treat high conflict divorce clients, so she referred her clients out ethically and worked on herself. And I really looked at that as, wow, that person was so in touch with their ethical obligation and within themselves to understand when they were impacted, to make sure that their clients' best interests were served above their own. And so sometimes we have to make those decisions as clinical supervisors. And that really ties into the ethical and legal. We need to have direct observation. We can't assess where our students or supervisees are at if we're not watching them. Watching tape is great, generally after the fact, but being in the room or on the other side of a mirror with them and understanding what's going on in the room is paramount, because then we can intervene and we can help them move past anytime they're stuck. And we can do the same thing with watching video. So, but I just want to highlight direct observation, whether it's on tape or whether it's in the room, is necessitated generally by our accrediting bodies and our licensing board. Give them verbal and written feedback. They need to know what they did right and what they did wrong, where they can grow. We can't just tell them we're doing a disservice if we're like, you're good, you're solid, you did a great job. What did they do a great job at? What could they grow on? What was a missed opportunity? What was an aha moment you saw the client have? What did your trainee or supervisee say that when the client had that aha moment? That is very evidence-based, and that's what we need to provide our supervision. Monitoring their performance, heavy-handed, once again, evaluating clinical skills. When we talk about paraphrasing, summarization, we talk about any type of clinical skills, we want to use evidence. I saw you use paraphrasing in this way, this verbalization led to this outcome in your relationship with your client or client aha moment, etc. And then encourage clinical skill and development and growth of our supervisees is another part of our role. So, last but not least, importance of gatekeeping. Our role is to monitor, and this comes from SAMHSA, monitor counselor performance. It's an important and often difficult supervisory task. Comes with managing staff or individuals, right? But this is a part of our job. KCREP highlights it as an ethical responsibility of counselor educators and supervisors to monitor, evaluate individuals' knowledge, skills, professional dispositions, and is part of our role. ACA, Code of Ethics, F6B, talks about gatekeeping and remediation as our ethical role of ensuring that nobody gets into the field that is a danger to others. And that danger is based upon all of our monitoring, our evaluation, and our work as clinical supervisors. Please don't think that we can just pass somebody because they are a student and they'll be fine. Or as I've heard before, the market will bear. That's fine if you're selling paper products that may not impact somebody, but that's not fine when you're sending a human being out there into the world that's going to work with vulnerable populations. And so gatekeeping is a form of remediation, and can move all the way from skills development and help, as I said, to escorting out of the field, and it's everywhere in between. It is paying attention to the growth of our supervisees and our trainees. It's also paying attention to our own clinical needs, our clients' clinical needs, our own professional growth, our own understanding of our code of ethics and our laws. And I put a few, by no means is this list even exhaustive of our ethical codes, but I highlighted the big four, and each one of these talks about an ethical responsibility in clinical supervision. So I think this probably covers almost everybody on the Zoom, that one of your professional organizations, or if you're duly licensed like myself, you're going to have two ethical organizations that highlight my responsibility in clinical supervision outside of my state responsibility for clinical supervision. So I said, we're almost done. I apologize. I had a couple of more. So to recap, our role to evaluate supervisees' performance is monitor, evaluate, and guide. We cannot evaluate if they don't know what they're being evaluated on. We cannot monitor if they don't know what they're being monitored on, and we cannot guide if they don't know what they're being guided on. So we have to communicate what level, at each level, what we're doing and why we're doing it. And this is a conversation, that brave conversation you have from the first time you meet your supervisee to the time you sign off on their final hours, and welcome them to the profession, so to speak. But we are doing this at each and every meeting with them. And that is generally for interns and for licensees, our future licensees, we're once a week. And I like to over supervise. Remember vicarious and direct liability? I'd rather find time in my week to over supervise than to ever have to sit on a stand. That's just me personally. So I want to know what my supervisees are doing constantly. Best practices, making sure that you go over informed consent with the supervisee, that your supervisee, that you contract and have an informed consent with the supervisee, outlining what their obligation is to you and what your obligation is to them. Have an expectation contract, have a learning plan, what they hope to grow while they're with you, what skills they would like to, that they feel that they're strong in, what skills do they feel they're weak in. That helps them start to look internally, which will help them once they become a clinician. And then boundaries. What are these boundaries going to look like? What are the boundaries that you have in place, right? Dual relationships, all the ethical boundaries we need to have. We need to make sure that they're still in place with our supervisees as well. And as I said, as I wrap up, these are a few of the supervision credentials that are out there nationally. NBCC has ACS, and then AMFT has the approved supervisor credential, and both of those nationally. And then NADAC also has an ACS approved clinical supervisor credential. All of those require additional education and testing, national level testing. AMFT requires also a paper on your theory of supervision. I believe NBCC also requires a academic paper on your theory of supervision as well. Oh, I will stop share. How are y'all feeling? Let's over too much information, not enough information. And if you any questions? I want to do some vignettes, breakout rooms, and play with some vignettes, or would you rather just have an open forum here? So a lot of good info, a lot of responsibility. It is. It's
open forum.
Open forum. Okay.
There's a small amount of us, you know.
This is an intimate gathering, right?
Yeah.
Oh, what are your thoughts? What are your thoughts on supervision? And I know it's a lot, and I was trying to be thematic so we could have that conversation. So it is a lot, right?
Hi.
Hi, Jacqueline.
Hi, I just want to thank you for this presentation. I'm considering to apply to graduate school this year, and I found this to be very helpful in considering what I should look for in the supervisor.
Awesome. Glad it could help.
Yeah, thank you.
A future counseling student. Right on. For my individuals that are providing supervision, what are some things that you found when you started supervising that you were like, I wish I would have known that. That would have been some valuable information for my school or my supervisor who signed off on my hours to tell me. What are some things that came out for y'all? And don't use names.
I can share a little bit. I'm sure others would have some to add, but I think just being really present and in the moment with the supervisee too, and giving your full attention, that can go a long way, and just building rapport and them feeling like you have their best interest. Because I think, that's the goal too, is to have their best interest and have the client's best interest. So just being really there in the moment and not distracted for me. And that's hard. I don't know about you all, but it's hard given so much that we're trying to accomplish outside of supervising folks. But I try to be very mindful of that. And then also just knowing that it's okay when you don't know an answer to something, because you will learn it. And like the thought of, I can get that information. So I guess not feeling like you have to know everything at once, but knowing that it's a gradual process and we can continue to grow in these areas. And sometimes that's the bigger and braver thing to do, is to not know and see how you can better support them with getting the better information. Anyway, that's my thoughts, but others.
That's it's knowing that you don't have to be the expert on everything right away, but you can find it. That's helpful. And I go back to, and I'm sure almost everybody has that experience when you're trying to be present with your supervisee. And my own experience trying to chase down my supervisor to advocate for my supervision, right? And it's hard because then you become a supervisor and you're like, oh, I have minimum 100 contact hours for clients, and then I get to supervise. I get to supervise, right? And you're like, okay, when do I fit them in? Between lunch, between running between group and group. When do I get to squeeze them in? But making time and being present, right? And not doing hallway supervision. Don't do hallway supervision, right? And I saw, about to start supervising for the first time in school counseling position. Any first time advice? Yes. Make sure you find somebody that you can trust and lean on. Know that you don't have to know everything, much like Michelle said, right off the bat, that you have somebody that you can seek supervision from, and that there's somebody that you can also seek consultation from. And I'm going to ask Dr. Zhang, because she is a school counselor, what her advice is for a first-time school counselor.
That is hard. I would say seek consultation, kind of like what Dr. Rivas is saying. Even as we're providing supervision, we need supervision so that we can provide effective supervision, especially if we're still learning the process. And, I think with school counseling, we have that clinical focus, we have that administrative focus, and then there's the programmatic area of focus where we're helping our interns try to figure out, are they implementing and designing, following interventions, following an MTSS model, or looking at the, evaluating those aspects. So I would say continue to seek consultation as you're doing supervision.
That's great. Thank you.
Don't be afraid to ask questions, right? Consultation, supervision, and I know we think we need to know everything, and I kind of probably was a little heavy-handed with that, right? But know when to ask, know when to reach out, If I don't know something, who do I ask? I have a mentor on speed dial, and I learned from him because he has a mentor on speed dial as well. And so I know I'm at least 2 degrees away from having a really good knowledge base. Other thoughts or questions or just your own experience? Yes, and if you're working with us, please use us. We're here to support y'all. So if you're taking our interns, we're here to help y'all. Dr. Rachel Marshall is a fieldwork coordinator, and just think of us as a support, that we are here as well. And Dr. Zhang, the other Dr. Rivas, myself, we're here. And I'm big on resources. I just sent you all a link to tip 52. It's from SAMHSA. Now it talks about supervision for addiction counselors, but page 8 talks about counselor theoretical models from Bernard and Goodyear. And the reason I sent that one to you, because it's a free version of a cribbed note version of Bernard and Goodyear. And then in the back, it has actually like contracting and expectation contract, learning plans. And since it's from the feds, it's not copyrighted, and you can actually make copies and use it for your own use. So I like resources. And so other thoughts, other concerns, or just wish I would have known this, or I know this and I feel pretty comfortable with this and I'm excited about this, or hopes, fears, dreams.
I don't know if anybody else wants to speak. I've done it for a while. So though, I really appreciate some of the training that's been offered, now through the website and here today. So thank you so much for your time, Dr. Rivas. I think, also just, using case conceptualizations, I find that in working with interns, that can be so powerful because it gives examples. And you can, there's actually case books that you can get that are great, that can give examples and kind of walk you through some of the different scenarios and how the theoretical approach and some of the strategy that's used, and you can also use people on your team to kind of think about how you might approach it given your school and your guidelines. And that has been really powerful. And I'd say one of the biggest things that our interns have really appreciated is going through case conceptualizations. And then as they get they're in field study, it's even more amazing because they start answering their own questions. So giving them that time to think about it and process it first, and then giving some feedback. We just did one of those in our trainings, and it was really powerful. So that could be a useful thing, especially if you're kind of getting into this and it's newer.
Yeah, case books, case conceptualizations are great tools, right? Other thoughts or questions, comments? It's like class. I'm just going to stare at y'all. Well,
Rivas, you said something that I think when you said, get comfortable with being uncomfortable. And I think as a counselor, I definitely understand that frame, but I think then shifting as a supervisor, it's such a different hat to wear in terms of that role. And just I see the gaps and I see where I need to grow in terms of having these brave conversations, and how do I have these confrontations, or how do I check? And as I'm having this metacognition where like, ooh, I should say this, but ooh, is that my own issue? And just kind of that's happening. And it's comfortable being a counselor, but to be a supervisor and do that work is challenging for sure.
Yeah, wearing those 2 hats, right? And it's funny when I said be comfortable being uncomfortable. Yesterday, I was working with some practicum students, and they were having a hard time. Like, can I say this to a client? Can I go there with a client? And I explained therapy has to be weird. Therapy is weird. We go to therapists and we talk about things we can't talk about with anybody else. So it's just inherently a weird relationship, right? And they were kind of like, yeah, asking people, people are coming talking about and somebody was like, but I'm really uncomfortable doing that. And so I did a roll with me. I looked at everybody in my group and I said, how many people in the room have pooped today or plan to poop today? And they all like looked at each other, and everybody raised their hand. I said, okay, You know, we're human beings. We have this life experience. We have these things. If our client wants to go there, that's where we go there, right? And it was one of those things. I'm like, oh man, okay, it's not really therapeutic, but it's that teacher mentor thing in me. It's like everybody poops. Okay, so we're gonna use that, you know, that classroom kind of idea. And yeah, sometimes, you know, switching that hat is it takes a bit to get used to, right? Chris?
Yeah, one thing I like to say is, Dr. Rivers, I was your student. I like the realness in you, just being real, just being humanistically real. Like, just tell it how it is. Sometimes it just be literal. Sometimes it just, that's how it goes. So I appreciate straightforward, being real. That's who I am.
Thank you. And that's one of the things is always when we're working with our supervisees, be yourself, and you know, don't try to change yourself as a supervisor to your supervisee, because you know they're going to work with you, or they can ask for somebody else if y'all just don't mesh, right? And you want them to know that, because that models advocacy for them, but that also they know who they're getting with you. If I'm a supervisor, you're going to get poop jokes apparently. Jacqueline?
Hi, another question for you.
Sure.
I have a mentor who's in private practice,
Mhm.
and I'm curious what your take is on some supervisors telling new clinicians that private practice doesn't work.
Private practice works. I had a thriving private practice in Colorado, and I'm sure some of these folks here have private practice. In California, you can't accrue your licensure hours in private practice. You have to, you can go to private practice once you get your license. But private practice does work, and it serves population. It serves, in private practice, you can work with court mandated individuals, you can work with private pay, you can work with pro bono, you can work with community agencies as a referral. So private practice is a great opportunity if that's the route you want to take. You can work also in an agency. You can work in for school counselors in school, for career counselors in a career counseling center, but you can also have a private practice if that's something you choose. One of the great parts of our field is that you can have multiple different areas that you work in as long as you remain in the confines, when I go back to this, legal and ethical practitioners, right? So follow the letter of the law, and how to, and the other doctor has put in private practice, you just have to know how to market and to run a business. But yeah, private practice does work for a lot of people. Some people, they don't like it. They like the camaraderie of working at an agency or in a team. And that's just really dependent on the individual. Oh, the other Dr. Rivas.
The only challenge with a private practice is we don't typically have training in our program to run a business. And that's effectively what you're doing. So if anyone's interested, tomorrow in person, we have somebody doing a workshop on how to start a private practice. So that's tomorrow, 10:30 at the University Union. But that's some people like to be given a case and work with that case. And some people like the part that is partly therapeutic and then partly marketing and managing a business and paperwork and make sure you're on to get new clients in and be on the phone and schedule them. So there's other aspects of it. So I think that's kind of maybe a personal take depending on how people talk about it. Can I do a plug while I have everyone here? We're also doing our first time we're ever doing our award ceremony tomorrow in person. And one of the things I just want to do with this group here that's supervising, I want to thank you all for the work that you do in supervising. It is thankless and you're doing a lot of mentoring and supervision and one-on-one, like you're really, the bulk of the experience for our students, I think research supports that the bulk of the experience, the learning experience happens in practice. So in practicum and in internship and in postgraduate, that's where they're learning. And so you're the biggest part of that puzzle. So we're trying to encourage our students to nominate site supervisors. So we ideally will have everyone honored at somewhere along the way annually. And I just wanted to do a thank you, like a sincere thank you for partnering with us and working with our students.
And I think that Stacy Cronin is having a question. Thought you could intern in a private practice under a therapist's license.
My understanding is, and I would say double check with the BBS. My understanding was no. I could be incorrect. It could have changed with BBS. I know that there's a lot of moving parts with it. So I would always say my advice is to reach out to the BBS, Board of Behavioral Sciences, and ask them if those hours would count or not count, because they are the final arbiters of what will count for licensure or not.
I
Does that
know
make
they
sense?
used to.
Okay.
When I was in grad school and doing my MFT hours, which was 20 years ago, you could then, but I mean, things may have changed. So I just threw that out there for Jacqueline, since she was asking, just to double check that if
Yep.
she's interested in the private practice area.
Yeah. Thank you. Yeah, I went back and I looked through the statutes, and there was like a weird thing about being a W-2 employee, having a W-9, and like being a 501(c)(3), and it was like, okay, now you're getting a tax code. This has nothing to do with clinical work. But yeah, just always check. Thank you, Stacy, for putting that in there. And I want to echo what the other Dr. Rivas said is, we appreciate you as site supervisors and partnering with us to, introduce the next generation of counselors, and whatever concentration they are, they're going on the field. And, one of the things that it is a thankless task, but I hold this out there because much like that really pivotal, significant individual that you had in your life, you can be that for somebody else in their training. And, that oftentimes will carry you through the thanklessness. And, the times you're like, why did I agree to supervise? It's because you're doing good for the field and for the clients and for the world. And we all know the world needs more good in it. And so I'm going to stop talking, but I'm going to leave you with something that I got from one of my professors. Do good, fight evil. And I'll let Dr. Zhang, if you have any parting.
I was here to learn. So, and I just appreciate, I'll talk to Dr. Rivas, because when he was going through some of these pieces, I thought, wouldn't it be awesome to do like this video role play of how to do clinical, administrative, and programmatic supervision, and what that would look like for supervisors. So, yes, Dr. Rivas, putting a check out that we need these videos.
I think that's next in our series of training stuff, Dr. Zhang. So we'll stay on after. All right, y'all. I appreciate you. Thank you for coming and to this presentation. I hope that you have a wonderful evening. We welcome you on campus tomorrow, and some events and some celebrations. And we thank you for working with our students and for everything you do. And please, we are support here for you all. We are here to help in any form or fashion within context. All right. Have a fantastic evening.